معلش هي مش جلستي، انا اتحطيت مكان الدكتوره، انا بعتذر.
Good evening, ladies and gentlemen, dear professors and colleagues. I am Ahmed Gaheen, Assistant Lecturer of Hepatology, Gastroenterology, Endoscopy, Mansour University. Today I am presenting a brief case scenario, and its title is Messages from the Black Box. Our agenda isn't an actual agenda. We having some data as input, we will process it and take it as output as a decision to help our patient. Starting with history, we have a female patient. All females are forever young, so the age is not important here, but for the medical purpose, we are having a 45 years old female patient with history of diabetes and hypertension. She is controlled, history of laparoscopic cystectomy 3 years ago. She gave an interesting history of blood transfusion 1 year ago, not related to medical procedure or surgery or hospital admission, just because she felt some weakness and fatigue, as she said, and some doctor told her to take 1 or 2 bags of RBCs to recover. By further investigation or further history taking, she doesn't have any apparent vaginal or GI bleeding. The complaint at our setting that she has long history of dizziness, dyspnea, and fatigue. Investigations, we ordered some lab investigation, as you see, and we found these abnormalities. From hemoglobin, we see that the patient had anemia. The MCV is low, indicating macrocytic anemia. Also, we have low levels of iron and ferritin, and the reticulocytic count is elevated, along with positive fecal to occult blood in stool, indicating a GI source of blood loss. What is the plan here? We have a proposed algorithm to follow in cases of suspected GI bleeding, starting from upper GI and lower endoscopy. We already did the upper GI endoscopy, and as you see, it was normal. We performed also lower GI endoscopy, and it was normal too. So what's the next step? According to the algorithm, here we move to the negative arm, which suggested to repeat the endoscopy. We already repeated the endoscopy, and also we didn't find an apparent source of GI bleeding. So what's next? What do you think we can do here? Okay. Already we have the algorithm, and we have some interesting modalities to go with, like capsule endoscopy, double balloon enteroscopy, even CT angiography or CT angio. Here we did CT angio for the patient because she was a poor patient. She can't afford any of the other modalities, and we did it at our hospital. We were trying to find something like a mass or a lesion, or we can define a bleeding spot through angiography. But the scan here showed something else interesting. We found a dilated portal vein confluence, as shown here, also as shown here, and that is the report. The report highlighted that we have a small sized liver in both lobes, dilated tortuous portal vein and its main branches, along with fusiform aneurysmal dilatation of portal vein confluence sized 3 by 3.7 centimeters with no intramural thrombus, also dilated splenic vein 70 millimeters. At last, we convinced the patient to perform video capsule endoscopy despite the high cost. The video capsule endoscopy is a hard pill to swallow. A hard pill to swallow because high cost and the concept of it's something strange. It's not like endoscopy, and actually it's a hard pill to swallow. You have the pill here having a camera and a light source that can take pictures of the GI mucosa at constant rate, along with batteries and a transmitter that send data to a receiver device that the patient carry with him. And then we obtain the video to be interpreted at our computers. The video here showed some interesting findings. As you can see, we have apparent vessels, we have suspected varix, and numerous red spots. That is the final report by the doctor who read the video. According to the location, this finding defined as innumerable red spots, philobacteria, innumerable apparent thin vessels, and suspicious ectopic jejunal varices. The extent, it extended from late duodenal mucosa till early mucosa, it almost affecting the whole jejunal part of the small intestine. And the final diagnosis was small bowel enteropathy. Do you think that may be a cause of the bleeding and the hemoglobin drop that we have in this patient?
Yes, enteropathy, and maybe some sort of portal vein collaterals means that maybe there is ectopic varices. Maybe.
Course.
Okay, and you have in this case, instead of you, I will do double ballonentoscopy instead of capsule endoscopy. طالما السي تي بتقول في بورتال فين.
From the beginning.
Yes.
السي تي بس احنا معلش يعني احنا كان المفروض ان احنا الاكزامينيشن والالترا ساوند يبين لنا
It didn't show an abnormality.
يعني شرونك الليفر وبورتال هايبرتنشن كل ده ما بانش في السونار.
No.
يبقى ده في مشكلة.
ده بقى مش موجود.
ده ما اتعملش.
تمام.
ما فيهاش
طب
سبلينوميجالي.
خلينا نقولها في الآخر.
هاخد منك نص دقيقة.
اتفضل.
أقل من نص دقيقة.
اتفضل يا فندم.
عشان أنا هم زعلوا من الكومنت الأولاني. أنا عايز بس أقول لك إن أنا بشكرك وفي نفس الوقت بلفت النظر. أنا لقيت الكومبلين أيا كان الكومبلين ده والكومبلين اللي هو بتاعك ده كل أمراض البطنة
موجود كتير
بتعمله. عملت شيفت على السي بي سي فانتاستيك. السي بي سي ده مفتاح التشخيص، مفتاح التشخيص. همشي في انهي اتجاه؟ فانت مشيت في الارض ديفيشنسي انيميا.
تمام.
الارض ديفيشنسي انيميا تساوي بلاد لوس
or
منين؟
decreased intake in case of some
فانا بس عايز اقول ان السي بي سي يا جماعه
مهم جدا.
هي مفتاح التشخيص وهتمشي في اي طريق. اتفضل.
اسمحوا لي اختلف بقى في النقطه اللي اتكلمنا فيها ان هو ليه نعمل دبل بالون انترسكوب الاول. هو دلوقتي الاي جي قالت لنا ان 5 to 10% of GI bleeding originates from small intestine, and in this case the most common this is the most common indication for small bowel video capsule enteroscopy, and it is the first line in this case. Okay, you have exceptions if you are having overt bleeding, you start with push enteroscopy, or if the patient is hemodynamically unstable, you start or you can perform urgent angiography. Okay, MDT. If you are going to have a discussion or MDT as we are doing now, which specialties would you like to call or to consult? The panel or the floor?
Okay. What is the question, please? Again.
Which specialties would you like to consult or call in to perform an MDT to find the
GIT and radiology. Endoscopist and radiology.
تمام.
الهيماتولوجي في الاول.
هيماتولوجي
حتى
Okay. We would be lucky if your institute or hospital have like multiple specialties so you can perform MDT, or we can do it the Egyptian way or the hard way. You can pick up your phone and make late night coffee shop meetings, or revise your contacts and have some call center skills. Actually, we consulted interventional radiology department asking about the possibility of coiling or embolization. Also, we have surgical consultation if we can repair this site of aneurysm, or even to perform, if it's hard to perform reconstruction, to go for proximal small bowel resection. Unfortunately, all these modalities were dismissed because coiling and embolization for interventional radiology, the aneurysm was fusiform in shape, not circular, so it's not a candidate for embolization or coiling. And for surgery, they told us if we can perform portography and during reconstruction will be very hard in such a case. And if we perform small bowel resection, the patient will have a small short bowel syndrome and the sequelae that we all know. Then back to our home, to leave the source of the problem itself and go to our endoscopy. What we can do, we can perform enteroscopy with argon photocoagulation. According to EGE, as you know, enteroscopy can be done either from oral side or anal side. Where to start؟ يعني حضراتكم قلتوا هنعمل انتروسكوب، طب انا هعمل الاثنين ولا هعمل ايه؟
هو اولا دكتور احمد ثانكس على البرزنتيشن كويس، بس انت رجعت تاني الانتروسكوبي بعد ما قلت ان جايد لاينز بتقول احنا نعمل كبسول اندوسكوبي. طب انا اعمل كبسول اندوسكوبي وبعد كده اعمل
يا دكتور البيبر دي من 2018 يعني احنا بنتكلم على 7 سنين
فاتوا. هو في الاخر
حالتك
هو عشان هو حضرتك دلوقتي قلنا ان في طب انا هعمل ابر ولا لور انتروسكوب؟
لا لازم اعمل ابر ولور الاول.
هتعمل الاثنين، انت هتبدا الاثنين، هتبدا انتي جريد وبعد كده تدخل ريترو جريد. تعالى لي
تمام ماشي، ما هو ده مش حاجه بالسهوله يعني. هو دلوقتي
لا طبعا الكلام
ده
مع الان اكسبيرينسد هاندز، لكن في الاكسبيرينسد هاندز وفي حاله زي كده وبتعمل بيها الانتروسكوبي بياخد حوالي ساعتين.
واحنا ورانا ايه بغير الاندوسكوبي؟
هو طب تمام، خدنا الفيديو كبسول دلوقتي وبينت لي المكان بتاع الفايندنج هي اللي هتدايركت مي ايذر تو ستارت فروم ذا اورال سايد اور انال سايد. ده الحاجه الثانيه. لو انا uncertain او ما فيش معايا finding في previous investigations, I will start from the oral side or antegrade. If I have overt bleeding, in cases of overt bleeding, I will start from the antegrade. The advantage of double balloon enteroscopy that gives me the therapeutic option that we can do either to take biopsy, smearing, injection, or even argon plasma coagulation. The message is here. Test before transfusion. That's something that we all, or many people miss, that if you have anemic patient, don't start transfusing blood. Just take a sample so your hematology friends won't be very upset from you. When we take samples after transfusion, it is mixed blood, you can get correct indices, and you have to take your samples before transfusion. Small intestine isn't a black box. You have many options to investigate small intestine, either by radiology, as we said, CT enterography or CT angiography, double balloon enteroscopy, or even video capsule enteroscopy. The video capsule enteroscopy shows minimally invasive approach to visualize the mucosal surface through the GI tract. It's a first line approach in evaluation of small bowel bleeding, and MDT is important to see or to get a proper way to help your patient. That is the real black box. It's not small intestine. And here we have two questions that left that we have to think about. Why the liver was small, and what is the cause of this aneurysm that we have found? I'll leave it to answer. That's our hospital, and thank you.